Yeah.
partly it's also recognizing, isn't it, that that there's really that these are huge areas, and we're only doing a brief scratch of the surface, really. But just coming back to clinical supervision, then the sort of and sort of either encounters or observations of other people challenging issues of race professionally. So sort of perhaps both of us thinking about those kinds of areas. What have we noticed about any encounters that you want to sort of think about in terms of racism, and also the observations of other people challenging those issues as well? So, I mean, I think the other thing that we've said prior to, in our conversations was certainly, I think, in my observations of the racism, is the reluctance that people have to sort of look at things and to ask about things. That might be sensitive or give offense or something like that, so they just stay away from it. And that's probably the thing that I've experienced most in my encounters. There have been other prejudices as well, but race hasn't been quite so obvious in that respect. More evident by its absence, like you saying that you know, how many other women of color managers are there in Aneurin and Bevan? Well, I mean, you're one that I know. We're both in that same organization, and I can't think offhand of any others. I mean, partly my job's a bit nichey, but oh, I do know another woman manager who's close to me in Aneurin and Bevan, but that's and we've got 14,000 employees here, so this isn't a small organization, is it? I mean, and I'm guessing there will be others somewhere, but I don't know about your encounters. But so there's racism by its obvious presence, isn't there? But there's also that by its absence, you know, by the absence of people of color.
And I'm aware that when I have those conversations with the people, they're not quite sure how to respond to those answers. So, well, when I've had like my pads and stuff, and I'm like, well, I'm aware that I'm very few people that is a woman of color in a management role. How can you support me with that? And they're like, they don't know where the support is because there's not that many people. But I think we come back to, I guess, those people who have those uncomfortable conversations. I think a lot of things come to my mind of people either not saying anything or people having uncomfortable conversations. So I do recall when there was a terrorist attack in Australia.
Yes.
So in New Zealand.
I know where
Jacinda
went to. Go on.
Where the Muslims were killed in the mosque.
Yes. That's right.
And nobody said anything. Nobody in my team said anything. Nobody said anything. And obviously I was like, it hit home a bit. But nobody said anything in work. And you know, when you go into work, people talk about, did you see this on the news? Did you see that on the news? But nobody said anything. And it was only when a patient came in the following week and they were like, oh my God, you were the first person I thought of. Are you okay? How did that feel for you?
Right.
And that's when it hit home that actually my supervisor didn't ask, my manager didn't ask, nobody in my team asked. And I was just like, it made me kind of realize that actually were people just uncomfortable to ask. But it also raises the question of, in that case, it was, he's got mental health issues. So when it's a person that is of white origin and they commit a terrorist act, they have mental health issues. But when there's a terrorist act and the person's of Muslim origin, they're a terrorist.
They must be evil.
So there's this big, huge narrative in the media. And I
totally
do recall having this conversation with my supervisor. And I was talking about lots of things about the media, and I said the media I said, you don't really expect anything else from the media, because to me, there's a lot of white privilege in the media. It is run by
elitists,
elitists, and a lot of white rich
right
men.
wing. Yeah, it's a right wing press. It's a very right wing press in Britain.
So that is what's going to be represented in the media.
Yeah.
And I said, and I did say my words were, and white middle class men. And I talked about kind of racist experiences that I'd had, and my supervisor's response was, "Oh, I feel like you're targeting my husband." So there was no validation of my feelings. There was no validation of my racial, racist experiences that I'd been through. There was no validation of anything.
Good example of white fragility there going on.
Yeah. And I was talking about white privilege. And there was no validation, and it immediately made me shut down. So I said, we're not doing this anymore. I said, I won't talk to you about my culture, and I will not talk to you about race anymore.
Right.
And there was kind of backstep, because obviously they had realized that it had hurt and it touched a nerve. But at that point, that immediate response made me feel not heard.
Yeah.
Especially with the topic that is, like we said, it can be uncomfortable to talk about, and I would welcome discussions, but if your discussion is going to be about yourself, and you're going to not validate my experiences or deny my experiences, that made my barrier come straight up, and I was like, I'm not going to engage in this to make you feel better. In where that supervision should have been a supportive, safe place for myself. It didn't feel like a supportive, safe place for myself to discuss those things.
And I think you know what that brings to my mind too is the notion of white fragility, a certain denial, I think, that's featured there, you know. That's still very out there, isn't it? Underneath that white fragility is a denial. I don't want to hear this. This is too painful. This is too difficult. I feel got at, you know. Whereas, well, you feel got at, mate. What about me? You know. But
and I think there was that not feeling heard. Especially when you bring quite vulnerable things, talking about racist experiences.
Absolutely.
It just felt
that's
not
extremely
safe.
vulnerable, isn't it? That's extremely vulnerable.
So I think when I had a new supervisor, I kind of explored that with the new supervisor. To say, actually, this is my culture, my race, my ethnicity is very important to me. So I want to lay that on the line now. And I talked about what happened with my previous supervisor and said that actually I want like a clean slate. And I was like, if things like that happen, I'd rather we have an open dialogue about this, and I would welcome a discussion about it. Even if you say anything wrong, I would welcome a discussion rather than a you not validate my feelings, or you shut me down. Because I've had people where I have worked, when I've worked in the service, and they've come to me for advice, and I've had, I have a patient who's from an ethnic minority. Do you think you could work with them? I think they'd be well suited to you. And then I've had the opposite, where a patient might be of an ethnic minority, they might be from Pakistani background or Muslim, and they were just referring them to myself because we were from the same background. So I'd have to go back to that person and say, what's your clinical rationale? Because if a person is white British, do you refer them to a white British person?
Yes, exactly. You know, the willy-nilly. Because, you know, oh right, you're ethnic minority. Okay, let me, you know, just kind of which doesn't add to anybody's understanding either. And as you say, you know, let's talk about the clear clinical rationale here.
And that was something like I had to combat when I first started. Was there were some people who were just doing that as someone ethnic minority, book them in with Sadila, book them in with Sadila, and I was like, this is not okay, because the person, yes, we've talked about how beneficial it can be speaking to someone from the same culture, but at the same time, sometimes people don't want to speak to someone from the same culture.
Yeah,
because there might be
absolutely.
shame around certain things and they don't want to speak to someone from the same culture
Yeah.
because there's a fear of judgment. So it's understanding that as well.
Yeah, and as you say, you refer one white British to another white British, there's a hell of a lot going on with the individuals, why
Yeah.
would you necessarily understand or get on with them,
Yeah.
just because of that?
Yeah.
Yeah.
And you wouldn't refer someone if they were homosexual, you wouldn't refer them to a homosexual counselor just because for that reason.
They're gay sort of thing. Yeah,
Yeah.
no. Well, I think, mind you, in my experience of talking, in some, that they have experienced that, but yeah, that you, in a sense, then it's sort of almost left up to you, isn't it, to put it to rights.
Yeah.
So then you've got to go. It's on you, isn't it, to go and have that uncomfortable conversation.
Yeah.
And and that's all very sticky and tricky, isn't it, in that sense? That feels already isolated. It kind of isolates and almost targets you a bit more, doesn't it? It's you putting your head above the parapet. Either I continue with these referrals or I have to go. And so either way, you're in a sort of confrontational situation, like it or not. Nobody else who's going to do it for you. What kind of, so I'm thinking, as we're talking about what kind of support you might need in those, and I think we can have a conversation about that elsewhere, but I think that what's occurring to me is that it's kind of left with you, isn't it?
And I think it's just being open enough to say actually what's best for the patient.
Yeah.
And that's what it comes down to is what is best for the patient. It might be that yes, seeing me would be best, or it might not be what's best for the patient.
Well, as you're saying, it's the clinical rationale, isn't it? So it's the expertise of the counsellor, it's what their interests are. It's a whole range of things, isn't it, that we kind of know about our colleagues and probably don't talk enough about. And
which is one of the reasons why I chose to kind of do further training with trauma EMDR, because I was aware with people from ethnic minorities and asylum seekers and refugees, there was a lot more trauma that was coming in. I was like, there's an area that I can develop myself to support the service and support that patient group as well. And have that cultural competency to be able to support them as well. So it's trying to support the service and the patient group to give them the best intervention that they would need. And it means that sometimes not having to use translators to ensure that we get the best support for them and they get the best journey as well, and they feel heard and understood. I think that comes back to, I guess, some of my values as a person as well.
I mean, you're finding out, just listening to a lot of things that I hadn't sort of thought about before we started this conversation. This is a real voyage of discovery that, there are opportunities there to think about, I think, in Sadila, in relation to, writing and so on, and sharing some of what we're talking about here more widely. That's just crossing my mind. You may or may not be interested in that, but all right, let's